Hello, I'm Dr. Daniel Griffin.
And I'm Dixon Dupommier.
And today we will be discussing scabies. This is actually one of my favorite topics. Can I have a favorite topic?
You can tell us why it's one of your favorite topics. I would like to know that, actually.
One of the reasons I think I like scabies so much is, I'll say, some of the success that I've observed.
Okay.
There's an organization called Floating Doctors.
Yes.
And it was started by a gentleman, Ben Lebrat. And initially, he formed this organization when there was one of the many Haitian crises.
Yeah.
And he got together with the Dream and a bunch of, fellow dreamers, other people that were wanting to do something. And they ended up with a boat. Somehow got this boat somewhat seaworthy, the Southern Cross, filled it with medical supplies, and this became ultimately an organization called Floating Doctors.
Got it.
And Floating Doctors, at this point, is now based in Panama. And they have started taking care of a lot of the indigenous population centers throughout the Bocas del Toro archipelago.
Nice.
And when they first went to some of these locations, 15-20% of the population was infected with scabies. And they introduced soap, which you don't really think about, to these communities. They started diagnosing and treating scabies. And now, when you go back, and I go and I work with them, and I do teaching for them.
Yes, I do know you go down there.
You go to these communities, and it's a rarity. You might,
I'll be darned.
let's say you see 100 patients, you might see just a few scabies
Nice.
cases a day.
Nice.
And when you do see it, it's much less severe. So this is one of those situations where, with not a lot of resources, but with a commitment to be going back, some real tremendous strides can be made.
Nice.
So it's one of those, we have so many times when we say, oh, I can't believe where the world is going. I can't believe children these days. And this is one of those where I've really seen some tremendous success, and it just it keeps you going to see stuff like this.
That's terrific.
So let's talk about scabies.
You bet.
Are you starting to feel itchy?
Just talking about the word scabies makes me think about itches, but no, I'm not getting itchy myself because for many years, as you well know, I taught a medical school course called Parasitic Diseases, and one of my guest lecturers was Dr. Robert Quads, one of the authors of our book, Parasitic Diseases, and he liked talking about scabies also. He says it's one of the few diseases you can actually catch by shaking hands with your patient. As a way of introducing the subject, and then he would go into the more extreme forms of scabies, and we started to talk about some of those with regards to the dermatologic manifestations. Mm-hmm. But it's not rare. It is not rare. And,
it's not rare in the tropics. It's certainly not rare in temperate, developed countries as well.
Exactly.
So we're going to keep an eye on you during the talk and see how many times you scratch, just to see if you do become, and the audience too. We're going to see if they start itching.
Really? Why would we ever do that?
Well, hopefully this will remind people of one of the biggest symptoms that people with scabies have is itchiness.
Yep.
Or pruritus, severe pruritus.
Yeah.
And often it's the mother bringing the child in and saying, my son, he just can't stop scratching. Mm-hmm. And so when we see it in children, we're seeing a lot of scratching.
Absolutely.
In adults, we see it as well. And there's a certain peak to the itchiness, which is at night.
Of course.
And so people will come in, patients will come in, individuals will come to be seen, and the chief complaint is often that I'm very itchy, or my child is so itchy that they can't stop.
Right.
And what is scabies caused by? You mentioned you're a parasitologist.
It's caused by Sarcoptes scabii, of course. Everybody knows that.
and is that a parasite?
It's a parasite. It's an arachnid.
Okay.
It has 4 pairs of legs rather than 3.
Okay.
It lives in the very superficial layers of the skin. It does not penetrate from the epidermis to the dermis. It lives by tunneling its way through almost dead skin. And it's hard to imagine how this organism actually causes itching of the skin. because of where it locates. But apparently some of the secretions of the mite make contact with the dermal layer as well and alert the immune system that something foreign is in their skin. And that reaction results in the itching that you get. And I must also say that Sarcoptes scabii is a parasite of humans only.
I think that's an excellent point.
It does not affect any other animal species. So if you say, well, are there any pets in your family? Well, there might be, but
it's not gonna.
You wouldn't have caught this particular entity from a pet.
You would catch it from someone else.
Somebody else. Are there other children in your family? Is one of them your favorite pet child?
Well, I think that's a good point. So the patients are going to come in with the itchiness.
Right.
They may come in with a rash.
Yep.
And Dixon and I, we talk a lot about scabies. I think probably more than most people talk about scabies.
Have you ever had it?
I have never had scabies, and when I tell most people, they are surprised.
I would, considering where you go,
considering where I
the
go,
contact that you have with patients,
you would think that I would have at some point when I'm going to communities where 1 in every 7th person has scabies. How do I not get it? And maybe that's a good thing to point out.
How do you not get it?
Well, I'm going to tell you. We're going to share.
I can hardly wait.
We're going to share. This is very transmissible. It is a highly contagious disease.
Yeah, right.
And when you diagnose a patient with this, you need to actually start thinking about the fact that you're probably at risk yourself. Yep. Particularly when it's a severe manifestation. So scabies, it's a mite, it's an arachnid, it's an ectoparasite that lives in the superficial layers of the skin. It can get to the point that there is so much scabies infection that there's a scabies superinfection, or what we call crusted or Norwegian scabies. Norwegian tribute to the researcher who described it, not something that is endemic in Norway.
Right.
And in that case, the person can be teeming with these mites.
And the cause of that is?
Well, it can either be immune suppression or hyperinfection.
Okay.
So we saw a lot of cases of this. We still see a lot of cases in people whose immune system is devastated by the HIV virus.
Sure.
But we also see this manifestation in children in the tropics.
Right.
And it has to do with the tropical locale. It has to do with the amount of infection. It also has to do with access to soap and water, right. Ability to clean these areas. But one of the things, and it's going to be one of the treatments, again, when you are treating a patient with scabies, one of the treatments we might be using a topical cream.
Yep.
And I always make a point of demonstrating the application of the topical cream and getting a large amount of it all over my hands in the process.
Got it. So, okay, that's called good barrier medicine, by the way.
But we should talk a little bit about how do we make the diagnosis. So someone comes in, and first we're going to talk about patterns. Dixon, you're familiar with this type of scabies we see in New York City, and how would you describe that?
Well, most of the common scabies that I've heard about, because I too have not had scabies, nor have I swathed an enormous amount of ointment over my hands to avoid it. The scabies that I'm used to hearing about are in children that come into the outpatient clinic either at Columbia or at the other medical schools around in the city.
Yeah.
And it's primarily infection in between the fingers, in the webbing of the fingers, as they like to say. But heavier infections, as you were describing, the mites can be found in other places besides there. Mm-hmm. And of course, you can affect other areas of your body if you have an enormous number of mites to deal with to begin with. Mm-hmm. But the ones that I'm used to hearing about are in between the webbings of the fingers, whereas, again, I want to say that this is only true for urban settings in the non-tropical world. The location of the rash, which they could find on the back or the knees or perhaps on the abdomen, does not reflect where the 3 or 4 mites per finger might be. So those are that's a mild infection with scabies, but I know there are many exceptions.
No, and I think that's great, because that was how I was first introduced to scabies. I trained on the Lower East Side of Manhattan, and we would see scabies on a fairly regular basis in individuals that are without a home, maybe living on the street. And it would be finding the burrows, finding the brown lines, having them scratch between the fingers. In that situation, the mite burden is usually relatively low.
Correct.
But the inflammatory response might be exuberant, and they might actually have a symmetrical rash as you described. So
that's right.
they're itchy, but where the money is, so to speak, where you're going to find the mites is going to be in the webs.
Right.
When I first started going to the tropics, to these areas outside the temperate climes, I ran into a totally different presentation of scabies. And in our parasitic disease textbook, we show pictures of where we tend to see the mite manifestation in the temperate climates.
Yep.
But when you go to the tropics, you start seeing significant involvement of the buttocks and scalp.
I'll be darned.
And one of the things that I've been we'll talk about in diagnosis, but I've been using a dermoscope to confirm in these cases, because for me this was different than the original I had been taught. So I think the things to realize is that scabies in temperate climate, low infection scabies, is going to be mostly in the webs, and we may see an inflammatory associated rash in non-affected areas. When you go to the tropics, you might see different distributions, or I will say you will see different distributions. You'll see involvement of the scalp, involvement of the buttocks. You will also find lots of children affected. There'll be little sort of dots that you're seeing from the lesions. So the diagnosis can be a little bit different patterns as far as the visual recognition.
Right.
And then the next is how do we confirm? Because it is nice to confirm.
Sure.
One of the things is that you can actually do scrapings.
Yep.
And sometimes you can, under the microscope, see the mites, which is, I think, quite exciting.
That is exciting.
Dermoscopy allows you to see in, and you can see the brown burrows, and you can see these chevron shapes that actually are you're actually seeing the mites in the skin.
Amazing.
So it's pretty, I think it's pretty exciting to be able to confirm it. Once you've confirmed it with these little delta wing chevrons, or your scrapings, or you're just confident with the pattern and the manifestations, then we can talk about treatment.
Sure.
And I think I alluded a little bit to a topical cream approach.
You did.
The application
What's
of
in that cream?
it's permethrin. So it's so not pyrmethrin, but permethrin. Permethrin. It's a 1% permethrin cream that we recommend, and you actually apply this to the whole body, which you can think in a small child is reasonable. Once you get into an adult, that's a lot of permethrin cream.
I'll say.
So in some of the times when I've gone where we're bringing medicines with us, you could have a large amount of permethrin you need to bring with you, particularly to a village where 15% of the population is infected.
Yeah, that's right.
Right, so it can be, and you put it on, you leave it on. They go to bed, you leave it on for 8 to 14 hours, and then you rinse it off the next day. This sounds a little bit easier than it might be in some of these areas where water is pretty limited, and the idea of you're going to take a shower, you're going to rinse it. How are you going to rinse this off? You're going to have to swim in the water if there is water to swim in.
Perhaps.
Maybe the water's not. So sometimes that can be a little more challenging than it seems.
Right.
And then you're going to want to repeat this a week or two later.
Oh my.
And some of these villages you might go to, there might be, you're getting the scabies burden down in the community, but there's going to be reinfection when the incidence is so high.
Right.
In addition to topical in severe cases, or where it's incredibly widely distributed, we might use ivermectin tablets. And again, we would do the same approach where you do the ivermectin and then you're going to repeat it.
So you might be killing more than one bird with one stone.
As we know from our parasitic disease knowledge, ivermectin is not just for scabies.
Nope.
I think that was like a commercial. Ivermectin is not just for scabies.
It's true.
But it does work quite well on scabies, and
Yeah.
particularly when you think about, a 70, 80 kilogram adults,
Exactly.
trying to cover them with permethrin
No question.
can be quite something.
Yep.
And the ivermectin you can actually use in children. Again, it's going to be weight based, and then there's going to be a repeat. And a lot of times when we go to areas where there's a very high incidence of scabies, we might assume that if the child is infected, that the family is infected. So we may even think about treating the whole family, because otherwise you're going to be passing it around.
Right. So what's the active ingredient in quell? We have always used the the commercial term quell.
Yeah, so Quell or Lindane was one of our
Lindane.
older.
Lindane is not good.
Yeah, it was one of our older
Not a good
treatments, and one of the reasons we stopped doing it is there's a neurotoxicity,
Yeah.
and so from side effects we've moved away from. But still, every so often I've heard people wanting to use it because they learned that 20 years ago in school.
No, of course. Of
So,
course.
but yeah, so we've moved on.
And then they forgot how to read.
Exactly. All right. Well, you did well, not scratching.
I didn't scratch one little part,
Okay.
but I'm dying to.
Okay. All right. Well, thank you for joining us again today.
Yeah, we'll see you again.